So I'd like to welcome Dr. Daphne Voineskos, medical lead of the Repetitive Transcranial Magnetic Stimulation Clinic and psychiatrist in the Poul Hansen Family Centre for Depression. Dr. Voineskos is an assistant professor in the Department of Psychiatry at the University of Toronto and also works as a clinician scientist at the Temerty Centre for Therapeutic Brain Intervention at CAMH. She completed medical training at the University of Nottingham, England, followed by specialty training in psychiatry at the University of Toronto. As Dr. Voineskos has a long-standing dedication to research. She's pursued a PhD through the Institute of Medical Scientists and Clinician Investigator program at the University of Toronto. Following her psychiatric residency training and during her PhD, she undertook a research training fellowship at the Temerty Centre for Therapeutic Brain Intervention. Dr. Voineskos' scientific impact is advancing in personalizing investigational and therapeutic brain stimulation techniques in treatment-refractory psychiatric disorders. Dr. Voineskos has been named the Labatt Family Professor in Depression Biology at the University of Toronto. Her early international reputation for her research and scientific potential has been recognized locally by the Department of Psychiatry, provincially by the prestigious John C. Poliani Prize in Physiology, Medicine, and internationally by the American Psychiatric Association. Dr. Voineskos' research program is focused on the neurobiological mechanisms and abnormalities in depression, with the translational goal of integrating these scientific findings into clinical care. Dr. Voineskos will be sharing her knowledge of rTMS and brain stimulation with us today. Welcome, Dr. Voineskos.
Thank you, Jenna. It's always a little uncomfortable to hear those bios read out loud, but you did a great job. I'm going to share my screen and I'm going to add a little caveat here. Let me put it into my view, which is that the title is, everything you wanted to know about rTMS and brain stimulation, but there's a lot we still don't know and a lot we're figuring out. And so I like putting this in brackets that it's almost everything you wanted to know about repetitive transcranial magnetic stimulation, which we'll call rTMS because it's a whole mouthful, and brain stimulation today. I hope it will be enlightening and helpful to you, but I'll give you a little bit of an outline here, and you'll see I have caveats and brackets throughout, and we'll go over, and I hope that you can answer at the end of this talk when speaking with others in the future, what exactly brain stimulation is, how we think the brain works, a little bit about rTMS, some recent advances and future directions in rTMS, and then we'll go over a summary to make sure all those concepts are solidified for you. So in these days, when we have to answer a question, the first thing we do is turn to Google. And so in preparing this talk, I thought the best way to realize how to explain this and how other people may have looked for information themselves is to do the same. So I just typed in, and I always like looking at these sort of predictive results when you type something into Google. And when I type in, what is brain stimulation, you see all of these things that come up. And the majority of information that comes up is about deep brain stimulation, which does occur at University Hospital Network and specifically at Toronto Western, largely in our neurosurgical department, but a little bit in psychiatry as well. And so we will go over that as well. But the focus today is on what we do at the Depression Center, and that is rTMS. But I always think that these things are interesting. Where do you think you would find a brain stimulation device on the internet? And you may actually, so we'll get to that in a second. So there are lots of different kinds of what we call therapeutic brain stimulation modalities or methods. I will touch on a few of them today. This is not an exhaustive list, but it's a chart that I made several years ago for a review paper that I thought might be a little bit helpful. And I'll go through it a bit, but we'll go through each one of these just in summary, because they are the ones that are sort of most prevalent in psychiatric and other medical field use. You can see that there are a few different ways that we would stimulate the brain, and largely it's either through electrical stimulation or magnetic stimulation. Our friend is here, rTMS, we'll talk about that today. Just to let you know that GA stands for general anesthetic, you can see that some of our more intensive types of brain stimulation require a general anesthetic and a procedural intervention. And then we'll talk a bit about the mechanism of action of each. So nice summary slide to keep in mind. The first one that tends to come up in people's mind when we talk about brain stimulation is electroconvulsive therapy. I apologize that this gentleman is not wearing more clothes, but the reason for it is so that you can see all of the monitoring that goes on in electroconvulsive therapy. The problem with electroconvulsive therapy, although it can be very effective for major depressive disorder, bipolar disorder, depression as a whole, and several other psychiatric disorders is that there is a lot of stigma. And largely it comes from the public view of electroconvulsive therapy, or ECT, which used to be known as shock therapy. A lot of it can come from this big movie that most people are aware of and have seen called One Flew Over the Cuckoo's Nest. I give a lecture every year to our residents and our medical students about ECT, and last year was the first year that people had not seen One Flew Over the Cuckoo's Nest, which made me feel quite aged, but also had some knowledge of ECT from popular culture and movies like, or TV shows like Homeland, and I think there are a couple other ones, movies where it's been shown as well. But the way that we think ECT works is that patients are put under a general anesthetic. They have a lot of monitoring that goes on. And with an electrical stimulus, we actually induce a seizure within the brain, which is the therapeutic part of the treatment. And what we know is that it activates and quiets down specific neurons in the brain through this treatment. It has to happen under a general anesthetic, and like with most types of brain stimulation, it's not a one-off deal. So patients have to have at least sort of 6 to 12 or up to 18 treatments a few times a week in order to feel some relief. It's very effective. So up to about 70 or 75% of people with depression who have not responded to medications or psychotherapy can get better with ECT, which is wonderful. But the stigma associated with it and some of the side effects, which are not tolerable for everybody, means that only about 1% of patients with what we call treatment-resistant depression, or depression that does not respond to medications, end up receiving ECT. So what about some of the other options? Well, I thought we'd cover DBS since it was the thing that came up when I Googled brain stimulation. And again, we do it at UHN. DBS also uses electrical stimulation. It stands for deep brain stimulation. And it actually uses a surgical implantation of sort of like a pacemaker for your brain. So there's a little piece that is attached to a specific area of your brain that sends a small electrical pulse to the brain when the stimulator is turned on. The stimulator is set sort of under the collarbone of the patient and can be turned off or on with an activating device that would be accessible through your surgeon or physician's office. In psychiatry, there is some evidence for its help in depression, in alcohol use disorders, and some newer evidence from obsessive compulsive disorder. It's been found to be the most effective in some of our neurological disorders, so things like movement disorders like Parkinson's disease. But it's an evolving field in psychiatry, and definitely a very exciting one. The big issue is that because it is so extreme, it involves brain surgery and so intensive, it's really saved for a very small percentage of people. Well, what about TDCS, which is transcranial direct current stimulation? This is the last kind of electrical stimulation I'll talk about today. And this is where you might be able to find that brain stimulation device on the internet. This is a very small, very simple device. It's powered by this 9-volt battery here, which also contains some circuitry. And essentially you put these little pads on your head in a specific area with a headband, and a very, very small electrical current is sent through these pads, which are usually wet with a saline solution or saltwater solution. And instead of causing a current in your brain, what it does is it lowers the threshold for your brain to communicate with itself or to allow neural pathways to be activated. I always say that this reminds me of those Dr. Ho ab machines that were advertised on TV. Again, I'm dating myself here, but that were advertised on TV in sort of the 1990s and early 2000s, because that's really what it is. It's these very small stimulators that can help to activate the areas over your brain. It can be purchased on the internet. I would not recommend it. Okay, so the last one to talk about before we get to the big show for today, which is rTMS, is magnetic seizure therapy. This is a type of magnetic stimulation, and it's sort of still in its infancy. It's only been around for about 10 years or so, and it uses a very powerful magnet, about as strong as an MRI that you would have. And the magnet discharges over and over again, sort of in front of the brain, or you could place the coil at the back of the brain. But again, it induces a seizure for its therapeutic effect. What we know is that it doesn't have some of those negative side effects that ECT does, where it could affect your memory or your cognition, but it does seem to be about as effective as ECT is. So I'll ask you to stay tuned for that one because we have a clinical trial going on at the University of Toronto, and we'll have some results for that sort of hopefully by the next Family and Friends Day. We'll have some results to share about that. But it may be one of the future pieces of this more intensive brain stimulation without some of the negative side effects and stigma that are contained by ECT. Okay, so let's talk about rTMS, or repetitive transcranial magnetic stimulation. If you have a family member or you are someone who's coming for rTMS or a friend who's coming for rTMS, this is what is happening when they come for treatment. What you see in this picture is our rTMS machine. That's this gray piece right here. And this black sort of double circle, which is actually in a figure of 8, is the rTMS coil. The rTMS coil contains a magnet that is shaped like a figure of 8. You may see some other shaped magnets as well for rTMS. But what we do is we place the magnet in a specific targeted spot over the person's scalp to target a specific area of the brain underneath. And the magnetic field passes through the hair, the scalp, and the skull, and activates or quiets down some specific neurons within the brain, so a specific area of the brain which is targeted. I'm going to save that for a minute because I'm going to take a little detour into how we think the brain works and why these brain stimulation modalities can be so effective for people where medications have not been effective. So the brain, of course, is a complex organ. We don't know everything about it, which is why I have one of my qualifiers in parentheses here. What we do know is that your brain absorbs information from the environment around you, whether that's understanding light and images, or absorbing sound through your ears, or using your vision to understand what's going on, or hearing speech from someone else. And these, we can classify all of them as signals from the environment around you, from your interactions with other people or other things in the environment. And though all of that information is coded and transformed into these electrical impulses, which is how neurons communicate with each other. After that information is transformed into these electrical impulses, the brain then interprets them and sends commands out for how to respond to those stimuli, how to respond to those signals. So whether that is that you've dropped your wallet and your brain has absorbed the information that your wallet is now on the floor, it then will send the command to your arms to pick it up, to your waist to bend over, to your knees to bend down, to help you coordinate to pick up the wallet and put it back where it belongs. So in summary, your brain receives a signal, interprets it, and then sends a command for a response. Now, in psychiatric illness, some of these procedures and processes, are not the way that they may be in healthy individuals. And we need to understand where exactly those abnormalities are. The first line with depression can be through medication, and that may affect how the neurons communicate with each other, because the medications affect the chemicals that help you send the signal from one neuron to another. But the neurons themselves communicate through electrical impulses, and I'll show you that actually here. So this is a little video. I hope you can all see it. And what you can see on the right here are actually 2 neurons seeing that there are electrical impulses trying to go from one to another and trying to make a connection between what we call their dendrites. So the little round pieces, and I'll play it again, but the little round pieces here at the end of each neuron, this is a neuron and this is a neuron, are sending out these branches, and literally they're trying to connect to try and make a new pathway in the brain. What we think that is, and what we understand that is the basis of how we learn and remember things. And this has an impact both in our daily lives, but also in psychiatric illness. The basis of this procedure is called plasticity. And plasticity really is how we learn and remember things. So if you think back to when you were a child and you learned to brush your teeth, you learned to tie your shoe. That's my favorite example. Initially, when you learned to tie your shoe, you had to think through all of the steps, right? You had to be reminded of the steps, think through each one of the steps. You make 2 bunny loops, you pull one over, you go under, and then you pull them through. I think I missed a couple. But now when you tie your shoe as an adult, you don't have to think about each step. You just look down, you see your shoelaces untied, you think I should tie my shoe. And sometimes you may not even think I should tie my shoe. You just stop what you're doing and tie your shoe. And you don't have to think through all of those steps. And what that means, here you can see on the left, is that initially the connections were being made in your brain for how to go through the process of tying your shoe. But now you've done it so many times that there are so many connections in this pathway. and it's done so solidly that you essentially skip all of the intermediate steps and you just do the process. And that means that electrical impulse is being passed through your neurons very smoothly, very quickly, without a lot of interference. That sort of speaks to the phrase that we learn in neuroscience, which is neurons that fire together, wire together. And so it's similar to initially trying to walk down or drive down a dirt road and then driving down the Autobahn in Germany when the connections are done so smoothly and so well paved. That is the process that I showed in this video. And that is what is going on when you learn a new process or you interpret signals from the environment. When we think about psychiatric illness, especially in depression, perhaps some of the more positive or helpful pathways are not being solidified so well in depression. Perhaps people are stuck in these well-rooted negative thoughts that we think about that can be rerouted with things like cognitive behavioral therapy, where chemicals can be redirected through medications, but sometimes they're so well paved and so well emphasized that it does not work to use either of those two or other types of interventions. And we turn to brain stimulation, which then will, especially with rTMS, reactivate or activate other pathways or silence those pathways in order to try and help people out of those ruts. Now, that's generally how things work. But now I'll take you to how rTMS works. And I see there are some questions, so I think we're going to answer them at the end. And really, I'm going to take you back to your high school science classes or your middle school science classes, where you may have learned about activating some old memories here with those neural pathways, Faraday's law of induction. Now, I did not think that I would be using physics so much when I went to medical school, but here we are. So Faraday's law of induction says that when you pass a magnet through back and forth through a conductant material. So this is the conductant material here that has a voltage being sent through it, so a current, and the magnet is being passed in and out of the area. You can actually cause another current to exist. So in this case, the TMS coil is the magnet and our brain is the other conductant material. And you can see here that this is a schematic, and what we do with rTMS is we plug it into the walls. There's an electric current plugged up coming from the wall that induces a magnetic field with a magnet held over somebody's head that then induces this electrical field within the person's brain. And that causes your neurons to fire, your neurons to pass information from one to another over and over again. And the way that that happens is that the magnetic field goes on and off. So that's where the repetitive in the transcranial magnetic stimulation comes from, because the magnetic field goes on and off. So this pulsed magnetic field. And then the changes in the magnetic field induce the electrical current in the brain, which stimulates the neural pathways to communicate with each other. If we move the paddle to different parts of the brain or different angles, or different parts over the scalp, you will actually stimulate different areas of the brain. So we take good care to make sure that we're stimulating the appropriate area to treat depression in our center. Which brings me to a little bit of information about major depressive disorder. We won't belabor this because this is the focus of our day and the focus of our work. But major depressive disorder really affects a lot of people around the world, 300 million people approximately worldwide. And these are numbers from 2017, so before all of the events of the last 2 years. We know that it's the leading cause of disease burden in North America and the second leading cause worldwide. And it does cost about $200 billion per year to treat, which is very expensive, but more importantly, it leads to a loss of contribution to life and a loss of enjoyment of life for individuals. And so treating it is a high priority for all of us working here at the center. So rTMS, so that you know, is approved by Health Canada in the treatment of major depressive disorder. This is a summary of a lot of studies, I think over 81 studies, which included 4,233 people who had different kinds of rTMS. And what we see here is that the majority of them, all of them, except for this funny one, which we aren't using, I believe, had anything on the right of this line shows that it was effective in treating depression. And so you see here that of all of the different kinds of research in rTMS, the vast majority of them are highly effective for people, or are effective for people to benefit and improve from depression. We'll talk a little bit about some of the benefits and some of the challenges of rTMS. As you gather, it's much less invasive than ECT. It doesn't involve a seizure. It doesn't involve an anesthetic. There are minimal side effects. We'll go over that in a moment. But there are some challenges as well. Similarly to some of our other treatments, this is a treatment that has to be done in person. For now, we can't send it home with you, unfortunately. It requires a special plug in the wall and a special machine and some accuracy in terms of where we place the coil and how we program it. And it needs to happen more than once. So these days we treat patients for about 4 to 6 weeks, so 20 to 30 treatments every weekday, so 5 treatments a week. And we'll talk about that a little bit more in a moment. And so you do have to come to the hospital every day. For some people in areas outside of Toronto where there aren't many rTMS clinics, that can really limit accessibility. And then there are some side effects, even though there aren't very many. There's some pain at the site where the stimulus occurs. People can have some fatigue and some headaches. But I say that with another caveat, because this is reporting from a study where some people got, sort of equal groups got what we call active rTMS, where this is the rTMS that is effective for depression. And this is a study from quite early on. And the other half of the people got what we call sham rTMS, or a placebo version, where there wasn't actually a stimulus going into the brain. And you can see that the numbers for people who had headache, relatively similar. People who had some discomfort at the stimulation site, relatively similar. People who had difficulty with insomnia, whose depression got worse instead of better, relatively similar. And then some other types of side effects. And so really, there wasn't very much of a significant difference between the people who got active treatment or placebo treatment. And we think that this is helpful for us to know that it's generally a well-tolerated treatment. The big question is, who will be helped by rTMS, or who might benefit? So there are some, I've left these in sort of the way, I've left these in the way that we discuss with our patients, the symptoms that they have. And we know that this is a table on how to evaluate people for rTMS. And I'm sorry that the text is so small, but it's from a paper in 2018 published by some colleagues in Texas by Sean McClintock. But we do know that the people who are more likely to benefit from rTMS are those who have what we call euthymia, so periods of feeling much better in between their depressive episodes, periods of feeling well. People who are less likely to have this chronic lack of pleasure or interest for sort of their whole adult life, although there are still people with that who do benefit. People who have sort of mild to moderate symptoms of depression, as opposed to the very severe depression that can come with what we call psychotic symptoms or catatonia, really severe depression where people need to be admitted to hospital. And also people we catch early on in their depressive episode. So while rTMS usually is given to people who have what we call treatment-resistant depression, which is perhaps they haven't responded to 1 or 2 treatment trials, people who have been through sort of the whole gamut of treatment trials of medication are less likely to respond on a regular basis to rTMS. And then there are some pieces about medication, which can always be changed. But because rTMS works to activate or silence your neurons, any medications that can interfere with that, specifically anticonvulsant medications that we use sometimes in psychiatry for what we call mood stabilizing medications, or our benzodiazepines, which are things like Ativan, Valium, Xanax, to use the brand names. These medications can really interfere with the way the rTMS works, and you have things working at cross purposes. And so usually we try to work with the provider who is prescribing those medications and with the patient to try and figure out a way that we can provide this new treatment for the patient that in a way that it will help them, as opposed to just to giving it to them while they're still on those medications. There are some recent developments that are very exciting. The traditional kind of rTMS that I've been talking about so far takes about 40 minutes. And I'm proud to say that over the past few years, this newer type of rTMS has been developed that was published in The Lancet in 2018. And it takes about 3 minutes, 3 minutes and 9 seconds to be exact. And there's no noticeable difference if you look at this chart in how people get better over several weeks with rTMS. If you have the 40-minute treatment, or if you have the 3 minute and 9 second treatment. You can see here that the high frequency rTMS, which is 10 hertz rTMS, that's the traditional type that takes 40 minutes, is the red line. And the blue line is what we call intermittent theta burst stimulation, which mimics the way your brain works a little bit more closely and only takes 3 minutes and 9 seconds to deliver a full treatment. That's your blue line here. And you can see that throughout the 6 weeks of treatment, people pretty much were improving in the same manner. This does look like a bit of a difference, but it was not significant. And at treatment end, and even 1 week after treatment, people got better either way. Now that opens up a whole new world for treating people with rTMS if a treatment only takes 3 minutes and 9 seconds, right? That means we can treat more people in a day. We can give people multiple treatments in a day and compress that 6-week course of treatment down to 1 or 2 weeks, which means potentially that people could come from far away and only take 1 week away from their family to have this very specialized treatment at our center. It means we could also potentially in the future, and I'm dreaming a little bit now, but take our machines with us somewhere else and help people in a remote location over a very brief period of time. I'll end a little bit, and I know I speak quickly, so I apologize, but I know we have some questions. I'll end a little bit with some more dreams and some more recent advances on top of how rTMS has changed in terms of its delivery and some of the research type things that we're looking to try and help rTMS improve a little bit more. And the first is how we can personalize rTMS. And so one of the ways that has already been put into practice is by, sorry, I'm going to pause that for a second, is by personalizing rTMS using people's brains specifically, as opposed to using sort of group averages of how we would direct the stimulus over somebody's brain. We now have this technology called BrainSight, which allows us in a 3D space while the patient is there, sorry about that, to look at the image of their brain. You can see very small here, this is somebody's MRI, and see where the coil, the magnetic coil, is targeting the brain specifically. So we have people sit in this chair with this sort of funky headband on, and up here, this is a camera that in the 3D space will show us where exactly the coil is targeting the brain. Now that's important for a bunch of reasons, but I think it's best visualized in this little video. So this is a blown up brain. When I say blown up, it's like puffed up, right? So you don't see all of the curves, all of the nooks and crannies of everyone's brain. And this is a schematic of how the magnetic waves from the rTMS coil would pass over a brain if it was smooth and flat like this. But that's not what our brains look like, is it? Our brains are actually really intricately folded. And as the folds come through here, you can see how the pattern of those waves change. So if my folds are different from Jenna's folds, or from Dr. Abby's folds, or from Marla's folds, why would the magnetic field travel the same in each one of our brains if we are having rTMS? And the answer is that it probably wouldn't. But one of the things that we're doing now is starting up a study to look at if we can model each person's individual brain, oh my gosh, sorry, to understand how the rTMS magnetic field will hit the specific area of that person's brain with their individualized folds, just like that. If this field is different than someone else's field, can we move the coil slightly, figure out exactly where to put it for me as opposed to for Jenna, for example? That will help rTMS be more effective for us. So really trying to personalize it. The second thing that we're looking at is how we can find markers or tests like you do perhaps in diabetes or in heart disease to understand who will respond to what treatment. And now in different kinds of medicine, you can do that at different stages, but because we can use the magnet to both treat and investigate the brain, we're trying to figure out if we can use some markers from the investigation piece of using these rTMS magnets to figure out who will best respond to rTMS. And we do that by combining the TMS coil with something called EEG, or electroencephalography, which means that our patients come in and they wear these funny looking caps with all these wires coming out, and we stimulate their brain with 1 or 2 or several different pulses of the TMS machine. And then we look at how their brain responds. And what we found so far, this is some recent work from myself and some upcoming work from my master's student, is that when people get active rTMS, their brain looks very different from when they got the placebo rTMS. You can see this is before people got rTMS, and this is after people got rTMS. Red means there's a lot of activity, and blue and green means there's very little activity. And so what we see is that the rTMS actually quiets down some of that activity in the brain, which is great because there are overactive circuits in the brain that we want to quiet down in depression. And these are all patients with depression, sorry. And then in this newer study that is in submission for my master's student, who's wonderful, named Rebecca today, coming up, she's just putting it in submission to a journal, and I'm sorry that the text is so small here, but that in the top, you can see the people on the top are people who responded to rTMS, and the people on the bottom graph are people who did not respond to rTMS. And this is that specific newer type of rTMS, that 3-minute type that I talked about. The lighter pink line is at baseline, and the darker pink line here is after they had their 6 weeks of rTMS. And here you can't even see the non-responders. The lines look the same, right? So that the electroencephalography waves that come out of the person's brain after they have rTMS, if they didn't respond, there doesn't seem to be much change. But if they did respond, there's this gap here. And afterwards, you see this lower wave that comes out of their brain with what we call TMS EEG. And so again, we see a similar finding to the earlier study, that their brains are quieted down a little bit by the rTMS if they're getting better. And that's really, really hopeful for us, because it means that we can start to move towards this goal that I have and that a lot of us have in psychiatry, which is to develop these types of markers to help us predict who will respond to different types of treatments, instead of just sort of trial and error, which I think can be a really frustrating piece in psychiatry, where you try one treatment and then another and then another. We can start to do what's called stratified or precision psychiatry. Stratified is the first step and precision is the second step, where we give people sort of these tests, like similar to going for a blood test to see whether potentially you have diabetes or you have some disease markers in your blood. And we can give these tests either with EEG or with some genetic testing, and see who is more likely to respond to what kind of treatment. And eventually, my hope is that this will really be integrated into our clinical practice. And we can start to do this as people come through the door and see whether you should first go, let's say in our depression center, potentially should first go for a course of psychotherapy, or you should first go for a course of rTMS, or you should first go to our MDPU to have some trials of medication. Now, that's a lofty goal, and I don't think it's something we'll achieve in the next few years, but it is sort of my dream by the time things are quite far ahead. I'll leave you with a summary, and you see in our numbers here, these are some of the questions I posed or some of the points I posed at the outline when I talked at the beginning of this talk. And I hope that now after this talk, you can answer some of these questions. So hopefully you'll be able to answer that brain stimulation as a group of therapeutic interventions to treat some of our psychiatric or neurological illnesses through different kinds of impulses, either electrical or magnetic, as opposed to pharmacological or psychotherapeutic treatments. We know that the brain is an electrochemical organ, and that experiences, memories, and skills are stored and communicated via these electrical impulses, and that in psychiatric illness, our brains can be, specific areas can be over or underactive. We know that rTMS now acts by these pulse magnetic fields and can activate or quiet down specific areas of your brain. We also know that we can always improve the types of treatments we have, and that personalizing treatment and establishing these biological tests are the next steps. So I'll open for questions. This is my favorite meme of the brain, because I think it really, really expresses how we feel, right? The brain is the most important organ to our body, but the brain is what's telling us that. And I'd just like to express my sincerest thanks to the Hansen family for allowing this to happen, to Jenna and Marla for your support as I'm new at UHN, and of course to Dr. Abby and to my mentor, Dr. Bloomberger.
Thanks so much, Dr. Voineskos. I really like that image of the brain and the personalization of rTMS, and as the GIF was kind of moving throughout it, it was really visual to see how the rTMS works. So thanks for sharing that. I see a few questions coming into the question and answer.
Do you want me to stop sharing my screen, Jenna, or do you want me to?
Yeah, sure. We could pull it down so then people can see us. And I also see there's a hand up. So if you have a question, if you can actually just put it into the chat, because I don't think you have the capabilities of asking the question or coming on a microphone. So please do put it in there. So there's a question about the video of the dendrite growth, which they said is truly awesome. I'm wondering what the time frame is.
Yeah, it's definitely sped up. And I don't think that that's in in someone's brain. It's neurons in a cell or in a cell culture. But it is great to see it. So it is definitely sped up.
Thanks. And then another question. So what if the patient fails to improve with rTMS? So they have rTMS not very helpful for them. Does that mean that their neuronal connections are really fixed and their depression so severe? And, what else might work? Is there any other options?
Yeah, so there are. I think rTMS is wonderful because it is sort of this much less invasive type of brain stimulation. People can continue to work or be in school, go about their daily lives, and still have benefit from it. But it does have some limitations, I think, as all of our treatments do. And one of those is that it's not always effective. About 30 to 50% of people will have some improvement. About 30% of people who have rTMS will get all the way better from their depressive episode. But that leaves a chunk of people who aren't going to respond. And there are still some things we can figure out, whether we're not hitting the right target for that person may be one option, but it may be that sort of approximately what you're saying, that their neuronal connections are not being changed or not being helped by rTMS. And in that scenario, a more intensive type of intervention, whether that's through brain stimulation or newer types of medication, is probably warranted. I hesitate to say that nothing will work, because I think in psychiatry, there's always something else to try, even when people feel as though they're at the end of the line. And one of the things that I think we have to remind ourselves a lot of the time as clinicians and physicians helping our patients is that this hopelessness and feeling at the end of the line can be part of the illness and something that people can really struggle with. And so sometimes I think we have to embody that hope and that drive to try something else and combine some new things to try and help people. So I would say that I haven't gotten yet to the point where nothing will work for someone. There's always something new or something else that we can try.
Yeah, and I can appreciate that, even that enthusiasm that you have, Dr. Voineskos, about there is other options and treatments. And so that I know is really a goal of us in the center, to try and as best as we can to find something that does work, knowing that sometimes folks do come in feeling a bit hopeless about where to go next. So another question, what are thoughts or research on brain stimulation for chronic suicidality, depression, and anxiety with this co-occurring personality disorder?
Yeah, I think, research has been a bit tricky so far because the initial research studies had very, very strict guidelines, really looking at people who only fit specific criteria. And we know that in the real world, that's just not the case. People have lots of things going on. They've had lots of different life experiences. And so I think what we've adopted and what some of the other centers have adopted is that as long as the main issue that people are coming for treatment is the depression, I don't think that we can exclude people who have some co-occurring other situations, whether it's also an anxiety disorder, also symptoms or signs of a personality disorder. I think those individuals can still be treated for their depression. What we do know is that sometimes our treatments purely for the depression can feel less effective because they don't address the other issues that are going on for somebody. And so it's a bit of a catch-22 a little bit, because it may feel as though some of these things are not as effective as we wish them to be in those scenarios.
Oh, Jenna, you're on mute.
Thank you.
You're welcome.
I was just saying another question about any theories why anhedonia is so non-responsive.
I don't know, but I think these are things that we can also start to explore, and a lot of our studies now are incorporating specific scales and assessments on anhedonia, so we can understand a little bit more about this. So hopefully we can have some more information in the future, but it's a tough one. I wish I had those answers.
Yeah. And then I do see a few questions just about the length of time that rTMS effects last. So any information that you can share about how long it's effective for and what happens when after treatment ends?
Yeah. So there have been some studies looking at what we call maintenance rTMS, which is where people come sort of once a week and then for a while, and then once every 2 weeks or a couple times a week, and really try to step down the treatments. But the evidence is really that people sort of start to become unwell again around that same period of time. And some of that really is individualized. So we have people who can remain well up to several years after rTMS, and are likely to remain well with some medication buffer, some antidepressant buffer, as opposed to nothing. But some patients will have some continued improvement after rTMS, will continue to feel well for up to years. For other people, it really only lasts, if they do respond, for a few months. The majority of people remain well for 6 months to 2 years at least. But for some people, they really can only remain well for 1 or 2 or 3 months. And I think in that scenario, and Jen, I know you and I have talked about this before, but in that scenario, we may try rTMS again and see how it goes the second time. But if that's really the pattern, then it may be that that person may also benefit more from a more intensive intervention. And so something along similar lines, like, or more intensive types of brain stimulation, may still be helpful, but may help the patient remain well for longer after, as opposed to rTMS. So in some ways, it's okay. It's not great because people become unwell again, but we do know that their brains respond to this kind of intervention. But unfortunately, rTMS is just not enough in those scenarios to keep someone well for a solid amount of time.
Yeah, thank you. And I'm kind of curious, as we kind of come to the end of talking about rTMS, you know, if someone wanted to get more information, or maybe they're hearing about it for the first time, or a family member or friend that's here, you know, where would you recommend that they go to get more information?
So I think they can go to our website. There's some information there. And then there's some good videos on YouTube that have been published by places like the Mayo Clinic, by CAMH. I think we had some from us. I'm not sure whether those are still up, Susan. I don't think so. And then reputable places for information. So I caution people that Reddit and Google chat areas are not great, but places like on the internet, like CAMH's website, like UHN's website, like the Mayo Clinic in the States, or the Johns Hopkins website in the States, all of those, or Harvard also has some medical reviews, I think, online. All of those places have great videos and pieces of information that can be more helpful. And I think they can always reach out to us, and we're happy to speak with people as well.